Hello everybody and welcome to our webinar this evening. I'm Teresa Forgione. I work with the Oracle Cancer Trust, and my colleague Sally is here in the background helping us run Zoom. There she is, you'll probably see her just behind me. There she is. So it'd be brilliant if you could all make sure that you're muted, just because we're recording this evening. And I don't know what it is. There's a law of virtual meetings that there's always somebody who has a dog that likes to bark and things like that. I have a cat that likes to dive into meetings, but that's not going to happen today because we are in the office. So it's really great to see you all here. I see some familiar faces, familiar names. Hi, Alison in particular. Hi, Anthony as well, and Robert. Hi. We are this evening joined by two great guests. So I'm going to just make sure that everybody's here. So we're here tonight to talk about biomarkers and how they might impact in the future people's ability to make choices in their treatment. So we have two really great guests with us this evening. We've got Janet West. Janet is, well, there's so many ways I could describe Janet. Janet is a broadcaster, an environmental scientist. She's pretty much a fitness expert as well, actually. She's an international traveller, and she's joining us this evening to share her experience of being diagnosed with tongue cancer in 2019 and some of the choices she had to make along the way. And we're also joined by Dr. Daniel Lin, who is coming to us from Newcastle. Daniel is waving. Hi, Daniel. We'll talk a bit more about Daniel and his work later on today. He's one of Oracle's excellent researchers. He is doing a 2-year project with us looking at whether there's an interesting biomarker that's been found in other kinds of cancers that could be useful in head and neck cancer. I won't try to explain it in any more detail because Daniel's the best person for that. So I think we'll probably just get on with it if you're happy to. So Janet, are you muted, unmuted?
No, I think I'm okay.
Yeah, lovely, yeah. Excellent. So I'm going to kick off just by asking you a quick question, which is, where are you now? How are you? What's happening? Tell us about your journey.
I'm in the UK, 2.5 years cancer free, brilliant, and generally keeping fit, eating reasonably well. I'll talk about that a little bit later. So yeah, and life is good.
That's fantastic. You talked a little bit about keeping fit and eating well. This has been part of your recovery, but maybe you could tell us, maybe go back to the beginning of your story, which actually is before you were diagnosed, isn't it? It started in late 2018. Could you tell us a bit about how you were diagnosed, when you thought something might be wrong, and what happened next?
Things started a little bit before that. As you mentioned, I was working as an environmental scientist, lecturer and TV broadcaster, all of which require you to talk. I'm 70 years old now and spend my retirement between the UK and France. I've got one son who lives in the US, and there was cancer in my family. There was breast cancer, colon and skin cancer. 12 years ago, I saw a small white patch on the side of my tongue. So it was my dentist that referred me to a consultant at the Northants Hospital. And they did a biopsy, but it proved to be negative. The white patch was leukoplakia and not the common lichen planus. They didn't tell me at the time that leukoplakia can eventually develop into oral cancer. Didn't have any problems particularly, but in September 2018, the white patch, which was on the side of my tongue, it was still there, and something wasn't right in my body. I had recurrent shingles, I felt tired, and for somebody who's fit, it was just really weird. I knew my body was fighting something, but I didn't know what. a friend in France who was married to a GP had a look at it, and he said, I think you need to get that scanned. Well, I came back to the UK, and 3 GP visits, 1 a month, I got told every time, your tooth is rubbing against your tongue. One even suggested I took a Ventolin spray and put the steroid onto the patch, which to me as a scientist didn't make sense at all. But by December 2018, I thought, this is crazy, something is wrong. So I demanded to see a consultant. Now, it was a 1-month wait to go to the Royal Berks, or a 3-month wait to the North Hants Hospital. I am so glad I went to the Royal Berks 1 month later. The first consultant, though, looked at it. Oh, I think it's just your tooth rubbing on your tongue. Go to your dentist and get your teeth filed down. And I couldn't feel any sharpness whatsoever. So I did. And it filed down, didn't make any difference. But January 2019, the pain started. Eating was starting to be comfortable. It hurt to sneeze, it hurt to swallow. It hurt almost anything that you did with your mouth. Coughing. I really wished at the time there had been a better way to diagnose what my problem was. Well, in February, they decided to do a biopsy. And I went on holiday, and Alice, my friend, is here. We went to Sri Lanka to a health spa before I got the result. And while I was there, a friend of mine in the UK said that there was a message that I was to have a CAT scan. And that didn't make sense. And my girlfriend said to me, who's a radiologist, normally they only ask for a CAT scan if they're looking for secondaries. As you can imagine, I was slightly perturbed. I returned to the UK, had the scan, and even the radiologist there said, oh, we're checking for, because they were doing the scan on my body, and I thought, I've got a problem in my mouth. So I said, well, why? He said, we're looking for secondaries. So I insisted on going to see a consultant, anybody, because I wanted to know what the result was. And lo and behold, found a consultant, and he thought I knew. And so gave me the sad news that I had stage 2 aggressive cancer of the tongue. I was on my own, and I remember crying all the way home on the train. The positive thing was that I was referred to Satish Prabhu, a delightful, caring surgeon who explained everything. He offered me 3 options, and he asked me, what was important to you? And I said, I want to be able to talk. I went home, and basically that night I decided to take the most invasive option because I wanted to try and avoid radiotherapy, but I wanted to have good speech. And radiotherapy can sometimes affect the voice box. When you get a cancer diagnosis, you get pretty low. So what I decided to do was to turn that low negative feeling into something positive. So I contacted a producer friend of mine at the BBC who followed my progress. The reason was because this was going to be quite a personal thing. It wasn't to become a star on the BBC. It was more to try and educate others so they wouldn't have to go through what I did. And I was delighted when the BBC aired my story 1 week before the D-Day celebrations, and I got 10 minutes, so it was brilliant. Last year, I created my own YouTube channel to help people with pre and post-surgery with exercises, tips, talking about speech, how to help muscles. And it's really been interesting because for people who have looked at it, watching someone who's actually gone through any sort of head and neck cancer has motivated some folks. And I've heard from patients in the Caribbean and India, where unfortunately post-surgery treatment is quite often not available. I belong to a support group called Heads Together, and many other head and neck cancer patients have found their GPs did not immediately diagnose the problem or refer them to a consultant. Dentists are in fact better placed to check your oral cavity, and any unusual patches, so my surgeon says, that last more than 3 weeks need to get checked. Well, in the 2 months pre-surgery, I could see the tumour getting bigger and bigger. And for the last 3 weeks before my surgery, I could only eat puree. I was off food. Now, I told Teresa that some of you might not like a little bit of a bloody image, but I'm going to share some images here. So you can see the yellow arrow is showing that was this tumour. When they did the operation, there were up to 14 people working on me. And what you see in the bottom is the third of my tongue that was removed. So quite an invasive surgery. Now, I was operated on my birthday, May the 1st, 2019. So I asked the staff, you know, normally if you have general anaesthetic, they ask you to count down. I didn't want to do that. I asked the whole team to sing happy birthday to me. And I remember probably about 3 or 4 happy birthdays, and then I was gone. There were about 14 people in the surgical team. And basically what they did was they removed that portion of my tongue, and then they took a flap out of my arm, which then with an artery and a vein was reconstructed into my tongue. But hang on, we've now got a hole here. So they took a patch out of my belly, which I actually insisted, you've got to do it below the bikini line. So they took that patch and then they put the patch in here. So after that, they did a neck dissection here and took out 44 lymph glands, which were then sent to pathology to see if there was any cancer in it. It was rather a difficult 2 weeks because when they told me there was no cancer in it, I thought, well, this is great. But they then said, we want you to make the decision as to whether you're going to have radiotherapy as a precautionary. Another big decision to make. But while I was waiting, and this is really important, I think many cancer patients would agree, I had to stay positive. So I did creative visualizing. There was my surgeon saying, there's no cancer in your lymph nodes. And lo and behold, that's what he said. So do I have radiotherapy or not? Basically, 1 in 3 people who have tongue cancer, it comes back. But if you have radiotherapy, 1 in 5 come back. So I thought the difference in that, I was prepared to take the risk and go for quality of life. So I chose not to have the radiotherapy because radiotherapy, if it is done, they can't usually do it again in the same place. So yeah, quality of life. And as I said, 2.5 years later, I'm cancer-free. Right, let's have a look at how I was in the hospital. So the picture on the left, that is me in intensive care when I woke up. In the bottom one, you can see I called this my green lizard. Basically, I had to avoid biting the flap because remember, it's got a blood supply in it and it was attached to the jugular and the carotid. This was the flap from my belly. And obviously that's where they took the vein and the artery. And my surgeon said to me, we had to take quite a bit because you've got a very long neck. And you can see here, that is where the neck dissection was. So recovery was painful and not very easy. But I learned a lot about pushing my body to recover. The wounds were a little bit horrific, as you saw. But the mantra for head and neck cancer patients is patience, patience, patience. It's an ongoing recovery. Keeping fit is essential, and patients need to appreciate that a weekly trip to the physio is not going to put the muscles back into how they were before you had your surgery. My French physio, after having been told in the UK, 8 repetitions 3 times a day, said, oh, good heavens, Janet, 100 repetitions 3 times a day. But hey, it worked. And unlike some cancers, like breast cancer, for example, you can have your breast removed with a mastectomy. But life then goes on relatively normal. With head and neck cancer, it affects your eating. It affects your intimate life. And there are many people who really struggle to eat, talk, and swallow. So let's have a look at food. So coming back from the hospital, they arm you with quite a lot of Ensure liquid, because you've got to put some calories into your body. And you can have soups. Then you might migrate to Shakes. One of the nicest combinations I loved were blueberries and Greek yogurt put through the blender, because as you can see here, it becomes like a mousse. Pretty much, I've had to become a pescatarian, even though people have said, well, try mince. But mince in my mouth is a bit like grit. And I have to be able to swallow certain things whole. So if you take something like fish, I can do this movement to squidge it, but I can't really do a chewing motion. And fish, all sorts of fish except monkfish, I can do that with. Generally, I'll eat vegetables a little bit overcooked, and I can even manage most cereals. For example, the Swiss way of having muesli, as long as I put it in the fridge the night before with the yogurt and the milk, it's nice and soft. So I rarely drink alcohol. I really love champagne and sparkling wine, which the bubbles work really well on my tongue. However, flat wine just tastes awful because I've got a different combination of taste buds. Now, talking to Teresa earlier, because she's a chocolate lover like I am, one of the nicest things, because I love chocolate, was that as soon as I could eat in the hospital, a friend of mine brought in some tiramisu, and it was a chocolate explosion, because obviously I'd lost quite a lot of taste buds at the side of my tongue, so I have a different combination. So basically, we need a better way to detect head and neck cancer and further detect it earlier and decide on appropriate treatments. Cancers come in all different sizes, in different places, with varying degrees of aggressivity. But having to make such life-changing decisions is hard when no one has the knowledge or experience. Being a scientist, I'm generally curious, so I've done that. But I'm really hopeful that Dr. Lin's work is going to make the decision-making process a lot easier. Over to you, Dan.
Thanks, Janet. Let me share my screen. I hope you guys can see that all right.
Yeah.
So good evening, everyone, and thanks for tuning in. I'm Daniel Lin, and I'm one of the ENT registrars in the Northeast region and the Oracle Cancer Trust PhD Fellow. And I wanted to share with you my project on exploring one of these new immune checkpoint as a biomarker in head and neck cancer. And that immune checkpoint is called IDO, which I will explain further as we go. So if you look at the news in terms of the BBC or the Guardian and just look up immune therapies for cancer, you get these sort of articles. And over the past 5 to 10 years, there's been quite an expansion in the field of immunotherapy for cancer. And so following along this field, there's also an emergence of an interest in biomarkers or markers of the condition in which it can tell us more about the biology of the condition itself. So head and neck cancer is the 6th leading cancer worldwide. And in the UK, the annual incidence is just increasing year by year. Symptoms include neck lump, hoarseness of voice, or pain and difficulty with swallowing. And as Janet mentioned earlier on, many of the existing treatments we have for patients can be very debilitating and have profound consequences on their function of speech, swallow, and function, and as well as cosmetic consequences. And so it makes it even more important for us to look for and explore ways in which we can personalize and improve treatments for head and neck cancer patients in the future. Now, I touched upon the term of immunotherapy or immune therapy. Let's just break it down into the different categories of types of immunotherapy, broadly categorized into immune checkpoints, which I will focus on mainly in my talk, and vaccines, similar to as if you were to get vaccines throughout life. There are also a research field in exploring developing vaccines to train the body's immune system to fight the cancer itself. And in a similar way, using harnessing the body's own immune cells or applying immune cells to try to fight the cancer in adoptive cell transfer. And the category of cytokines and immune modulation you see below is more focused around adapting the body's signaling to help aid the immune system and clear the cancer. So onto immune checkpoint blockade. What does that mean? What does it really involve? This schematic just shows that in the body system where you have a tumor cell, the tumor produces or has a signaling molecule on it, almost like a badge or an identification called a tumor antigen. And that can be recognized by the body's immune cells. A common immune cell you might have heard of is the body's T cells. And these cells can attach to these signaling molecules and either recognize, or this signaling molecule from the tumor cell, in this case, can inactivate our body's immune cells or T cells and prevent it from clearing cancerous cells. If you apply an immune checkpoint blocker, a molecule that blocks this signaling, can then reactivate our body's immune system and help it clear the cancer. So we think about immune checkpoint blockade almost like a traffic signaling system in the body. And as I mentioned, with the inactivation of the immune system versus re-enabling it. In terms of immune checkpoint blockade and the field in general, it started very firstly with the immune checkpoints, which you see on the top right of the screen: PD-1, PD-L1, CTLA-4. And so these are the very early immune checkpoints, first discovered and in the early days applied to the treatment of skin cancers, melanomas, for instance. Most recently, the Nobel Prize was awarded to the discoverers of those immune checkpoints. But when we come back to the situation of head and neck cancer, the biology behind it is less researched in comparison to other cancer. And when we apply these immune checkpoints to head and neck cancer patients, the published literature shows that up to 23% of those patients actually respond to such treatment. So we're in an exploration phase of trying to find the next immune checkpoint inhibitor or the next immune checkpoint biomarker that can tell us more about the disease process and about the cancer itself. This brings me to IDO. So that's the enzyme or signaling molecule that we're interested in exploring at Newcastle University and Newcastle hospitals. And this molecule, we can measure its activity in the patient's blood sample. If we think about cancer and its in its interface with the body's immune system, you can almost think of it as a scales and balance. So either tipping towards progression of the cancer, where gradually the cancer and tumor cells prevent your body's local immune cells from clearing it, versus on the other end of the scale is trying to harness your body's immune system and to help clear it, to clear the cancer, identify and clear the cancer. So there is this interplay between inflammation, the body's immune system, and cancer that's becoming more and more evident in the research. For instance, in our group, our interest in IDO is focused in particular looking at its signaling and being able to measure it both in the body's circulating blood as well as within the tumor tissue and lymph nodes itself. So some of the unmet clinical needs for head and neck cancer include identifying such predictive markers of disease and help to improve the treatment choices for patients and provide evidence to then support these decisions in going down a particular treatment choice or another, as Janet mentioned earlier, either choosing surgery or radiotherapy. But also in the back of our mind, whenever we are treating and managing head and neck patients, is also to consider what's most important to the patient in terms of their quality of life. So that also factors in the decision-making process. Go to the next page. Recently, our group published in Nature Reviews on the importance of the body's tumor draining lymph nodes in its signaling and understanding more about what is happening at the tumor environment. And so that plays an important role. And in that sense, we're also collecting and biobanking our patients' tumor draining lymph node tissue to then also test our biomarker IDO. Our group has also published in Cancer Research the importance of IDO in distinguishing between patients with lung cancer whom have differing levels of IDO activity. And that is when followed these patients on for between 5 and 10 years, it's becoming more and more evident that differing IDO activity has an impact on the ultimate survival rates of those patients. If you just look up the definition of biomarker, as I've been mentioning all along, what does it actually mean? Essentially, a biomarker is a molecule, a biological molecule, which can be found in our body's tissues that's measurable and is a sign of an abnormal process or condition. In our case, our interest would be in head and neck cancer, so a biomarker for head and neck cancer. And our goal is to explore IDO in that sense. Just a bit about my my journey to come up to this point. So I started with an academic clinical fellowship in the Northeast region with generous small pump priming grants from the Wellcome Trust and the Royal College of Surgeons of Edinburgh. Following on from that, the Royal College of Surgeons of England supported me with a one-year surgical research fellowship to explore IDO in head and neck cancer. From there, I took time to continue with my clinical ear, nose, and throat training, and subsequently was generously funded by the Oracle Cancer Trust to complete the remainder of my PhD in the years 2 and 3 on this project. So it's a long journey coming, but very excited to be a part of it and proceeding with it. This is our research team and my supervisors, and you can see this close integration between the Newcastle Hospitals, Newcastle University Translational Immunology Lab, and our pathologists at Newcastle Hospitals in making this an integrated and multidisciplinary approach to also studying this important topic. My project design included obtaining research ethics approval and consenting and recruiting patients. To date, we have nearly 170 patients recruited to the study, and the great majority of them have also donated their tumor tissue from surgery to the study, and all of them have donated blood samples for me to process at the lab and to study this biomarker IDO. And so I'm currently in my third and final year of my PhD, and my focus really is on gathering the data from these samples that have been biobanked and tested, and to then help draw some conclusions about what we have studied so far. The major impact of a study like this, if we go back to what Janet had been mentioning early on, in the patient journey for head and neck cancer, it involves, in some cases, several points of decision making. And those can be very critical steps. Not only are we taking into account the decision or what's valued by the patient in terms of their function, but also we have to consider the biology of the disease that we're treating itself. And so if we can have a molecule that can tell us a bit more about the underlying condition, and if we can measure it, for instance, in the blood and tell us more about what is actually happening at the tumor tissue site, then that can hopefully inform our treatments and help personalize treatments for patients further down the line and in the future. And so that's the ultimate goal. That really is, at this point, we're at early stages and taking the steps to gather the data and also map the patient's IDO activity with time. So the conclusion is that at this point, we need better biomarkers for patients in terms of grouping them for head and neck cancer treatment. And hopefully our study and exploration of IDO will help facilitate future clinical trials and improve patient decisions and treatments in the future. So this is a recent publication which I completed on a review for IDO in head and neck cancer. And I'd like to thank the following members, in particular, the Oracle Cancer Trust, as well as all the patients and participants in this study.
Wow, Daniel, thank you so much for that. I've seen your presentation before, and I get new stuff out of it every time I hear you talk through your work. One of the things that strikes me is just how many people are making this work happen. It's your supervisor team, but also how many patients have contributed by giving consent to have some their biomarkers tracked. How many people are involved?
Yeah, and so to date, it's 168 patients recruited to the study, and we're still continuing recruitment through my third year. The end of recruitment is aimed for August of next year, and I'm sure we'll get more patients. But really, this is the important foundation step of gathering the evidence, gathering the samples, the clinical samples, and do the tests that we need to. And so it would not be possible without having these generous patient recruits.
Yeah, it's your work. I mean, I see this in a lot of the work that Oracle does, but in particular with your study, just how much of a team effort it is. It's the patient community, it's individuals. When having to make decisions like Janet talked about, with all of that going on, still thinking about contributing towards the science and contributing towards people in the future's treatment, I think it's quite extraordinary. And I think it takes a special person to do that, as well as special people get over head and neck cancer. And it's what a thing to have to deal with, honestly. So I thought at this point it'd be quite handy just to bring Janet back in, because I've just wanted have a sort of couple of points of conversation, really. So Janet, unmute yourself. And so Janet's been an absolute star. She's had that cold I can't believe it's not COVID. So she might splutter a little bit because we've made her speak loads this evening. But one of the things I was going to ask, Janet, you've talked a bit about the videos that you've produced and sort of the holistic side of recovery. I wonder if you could just talk a little bit about what motivated you to do that, and why do you think they're so popular?
Can you hear me? Yeah. Speaking to other patients, I can remember one particular gentleman. He said to me, "I can't lift my arm up more than that." And I said, "So what are you doing?" He said, "Well, I go to the physio once a week." And I realized that a lot of people, if they haven't been fitness, not a fitness fanatic, but if they haven't had a regular fitness program, it's very difficult because initially you've got to spend a lot of time working on the muscles. So what I thought was I'd learned a lot by dealing with a physiotherapist two physiotherapists in England, and the physiotherapist that I had in France who'd helped me with a dancing accident a few years ago. And he said, "You're fit, so 100 repetitions." And it wasn't just one exercise, it was several. So that process probably took me a couple of hours. Obviously, some people can't do that. So I had the idea, during lockdown, there was a Pilates video that I found, and she was in the south of France. And I thought, how nice to watch a video that's actually got the background of the sea, etc. Well, mine's not by the sea, but I just decided to make the video, and Pete Brady, who is part of Heads Together, who's got all the editing equipment, he's been brilliant. And we've put quite a few videos together, but it's just been really nice. I got told when I put a YouTube channel together that I get a lot of trolls. I've had one strange one, but otherwise I've had really nice comments, and particularly the lady in the Caribbean who wrote and said, "I've got no friends, I've got no support, and I've got no family, and I was feeling suicidal, and you've inspired me." So I get quite emotional there, but if the videos are helping, that's great. And I've got 3 new ones that I've just shot. One is how to eat at home and how to eat in a restaurant, what substitutes to ask for. The anterior deltoid muscle, because when you can't lift your arm up like that, because of the muscle over your collarbone, you have to use a different muscle, and that's not normal. And the other one is, I thought people aren't going to carry on doing this many exercises, so I'm going to be doing a 10-minute workout for head and neck cancer patients.
That's great, Janet. I mean, one of the things I was just going to share, and I'll send some information around after today, but I'm going to share my screen because I've got the YouTube video channel up. So this is just an example of the different videos that Janet's produced, improving speech, where to get support, rotator cuff muscle exercises. Oh, it's all excellent. And there's an excellent video of Janet doing some indoor skydiving as well, if anybody is feeling so inclined that they could aim for something like that.
That was to celebrate 6 months cancer-free.
Brilliant, brilliant. So yeah, I mean, Dan, I was going to ask you as well, Janet, you've talked about people sort of dealing with the after effects of their treatment, and sometimes those people would have had to make choices about the kind of treatment they had. And I'm thinking, Dan, we've talked a bit, haven't we, about how it's impossible to crystal ball gaze. But you've said, your hopes are that the IDO could be a really useful biomarker that could help inform people. Why do you think it's important to sort of look at biomarkers? And are there others out there that you're aware of? Because IDO is one option, isn't it? Are there others that have been published?
Yeah, so in terms of biomarkers, I'll answer the first. So why IDO? So because we've shown, our group has shown that IDO is a useful prognostic biomarker in lung cancer patients, our hope is gathering the evidence that we can use IDO to tell us more about the biology behind the cancer. To date, in terms of our staging of head and neck cancer and our ability to understand, classify it at the very outset, does not have enough of the biomarkers. For instance, take for instance, such as breast cancer, where you have, triple negative breast cancer, or other types of other cancer types, which have at the outset these biological tests that are run on them at the very start. I mean, for head and neck, we often talk about whether the patient has an HPV associated head and neck cancer or a non-HPV associated head and neck cancer. And that is also a type of biomarker as well. But in terms of using IDO, we think that it can tell us more about the immune system and its interaction with the cancer itself.
Great, thank you. And I mean, because it's been shown to be useful in other forms of cancer, it gives it a real head start, doesn't it, as a potential biomarker of head and neck cancer?
Yeah, absolutely. And Teresa, I think going back to what you had mentioned about the number of patients that have been recruited to the study, with our preliminary results from the IDO study, where particularly those patients who are receiving radiotherapy treatment, we're also following their IDO activity levels throughout their treatment and recovery and follow-up. And we're starting to see quite interesting variations in the IDO activity. And our hope is to use that to tell us more about, to use that to understand if there are any differences in their cancer biology. So that still requires a bit more of data analysis and to understand that, but we hope that we can understand it better with IDO.
I mean, that's really exciting that even at this point in your study, because you're actually relatively early stages of your work, aren't you? It's exciting that you can already start to see some patterns emerging that obviously you want to validate as your work continues.
Absolutely.
But yeah, that's really promising, isn't it? I'm mindful that we've had a few questions come through in the chat, and I'm really, really keen that we make sure that we let you all go on time at 7:30, because I'm, it's strictly on tonight, but everyone's got things on this evening, so I won't keep you too long. So we're going to start firing questions at you, Janet. Okay. So we've had a question from Anthony. Hi, Anthony. You've asked a question, how do you interpret the IDO levels, and can the level of IDO be linked to the different types of head and neck cancer? It's a really good question, actually, because there's so many different kinds of head and neck cancer out there. So yeah, Daniel, I suppose this is one for you. Yeah. Certainly not for me.
Sure. So in terms of interpreting the IDO levels, at this point, because we're measuring the baseline IDO activity in the patient's bloods that we've recruited to the study. And of the over 100+ patients, we've started to gather an average, and we're able to use that and compare it to what's published in the literature about what is a normal reference range for IDO activity. And we're able to make some comparisons with, patients with head and neck cancer. How does that compare with patients who are otherwise normal, healthy volunteers? And those IDO activity levels are different, as well as within our patient group itself. There are head and neck cancer patients with very elevated IDO activity levels that we're measuring in the blood, as well as those that are less so. In terms of your question about linked to different types of head and neck cancer, we're focusing on head and neck squamous cell cancer. And again, even with that, you have different sites within the head and neck. So we're talking about, for instance, tongue, head and neck cancer, oral head and neck cancer, or oropharyngeal further back, and then even further down towards the voice box, laryngeal cancer. These are all squamous cell cancers of the head and neck. And looking at those patients, we would be interested in whether the IDO activity levels vary in those patients. And as I mentioned about the HPV association, that being a biomarker, is there a link between higher IDO activity or lower IDO activity in those patients with HPV-associated head and neck cancer? So those are the questions that we need to start to answer with the data that's coming through. Your third question, how will the results of PhD be adopted to treatment pathway? It comes back to what Teresa was mentioning. This is really the early foundation, early groundwork for what is to come in the future and our hopes to use it as a biomarker. Finding the evidence early on will help us then support further grants and expanding this study to continue to follow up our patients. To date, if you think about my entire pathway up to this point with the research study, some of the earliest patients recruited to the study to date have just completed 3 years or just over 3 years of follow-up. And really, we want to see how these patients are doing up to 5 years or between 3 and 5 years. So we're still also waiting for those patients to continue along their patient journey to get to that point. And hopefully, with all the information that we've gathered up to that point, we can use IDO to inform better treatments in the future. So I hope that helps answer things.
That's great, Dan, thank you. And you've just brought home to me again what a commitment it is for these patients who are getting involved in your work, that they continue to provide blood samples and tissue samples for that whole period of 3 to 5 years. I mean, that's quite a thing. So I don't know if anybody who's in your study is actually joining us this evening or might end up watching this video, but a big shout out and a thank you to everyone for getting involved. We've had another couple of questions. We've got Anson was asking about, had a question for Janet. Anson, actually, do you want to unmute yourself and ask a question, or do you want me to?
Yes, okay. I'll turn my screen on. Yeah, so hi, Janet. So it's really
Hi, Anson.
Hi. Interested in, so you mentioned about sort of dentist, and so when I had my sort of tonsil cancer and they're odd shaped, pointed out to me by my ENT consultant, they looked really odd in shape, and I'd noticed that myself for maybe like a year or more or so. But yet my dentist has seen obviously my tonsils and mouth for quite a long time during and before that, and I wonder whether they receive any did you receive any training in checking out for abnormalities like that at all, or thinking of ways just to catch these things earlier is better.
Yeah, yes, they do now. In fact, last year I was with my surgeon giving a talk to the hospital in Henley to a group of dentists and patients and GPs. I think the fact that a dentist is looking at the oral cavity every day compared to a GP who's literally from the top of your head all the way down. Obviously, if it's the voice box, that's going to be difficult, but we're talking about white patches or strange things that they can actually see. I actually went to see my dentist today just for a checkup and everything was fine, but he said he's now referring, that's one dentist, 10 people every month.
Wow.
So he and the hygienist are very au fait with how to identify or even make a referral.
Yeah. Okay, that's brilliant.
And I think what my surgeon, if you look at my YouTube channel, there's the BBC video on there. Mm-hmm. And my surgeon and I are being interviewed at the end. And one of the things Satish Prabhu says is, if you have something that's a bit strange and it's still there 3 weeks later, you absolutely have to get checked. Yeah. I think it's a lot of people probably see something and think, oh, it's just an ulcer or it's whatever. And it could be on your cheek, it could be under your tongue, it could be on the side, or in your case, the tonsils. But if you've got a problem and it's more than 3 weeks, get something done.
Yeah. Okay, thank you.
Thanks. Wise words, Janet, thank you. Anson also made another comment earlier, which is he's also a proponent of staying fit as a way of getting through these sorts of things. So you two are kind of kindred spirits in that respect.
Well, I also put a commentary so that it's important to be fit before an operation as well, because at my age, that certainly helped me get through the surgery.
For sure. And you mentioned that you got to know your physio because of a dancing injury. So it's good in a way that you're fit and you'd managed to sort of build up these networks of people who are there to support you. It's a great example for us all, actually, to make sure that we're primed and ready. In fact, you told me something ages ago about how you prepared for surgery because you were so keen that you were going to be able to retain your ability to swallow and speak. Could you just mention a couple of the exercises you did in preparation?
Well, this was totally out of my head, but I was so nervous that I wasn't going to be able to speak. So I thought I need a trigger. And I used going to the loo, to the toilet as the trigger, as one goes a few times a day. And I'd put my tongue in the bottom of my mouth. And I think, you know, if you try it on your own, it's very difficult to talk. But I was forcing different muscles to make the sounds. So I felt at least if I wasn't going to be able to talk through normal ways, I was going to have some modicum of speech. And as it happened, my friend Peter, when he came in as I was coming out of ICU, he just said, hello. And I said, hi. So I'm very lucky. But one of the tricks that I found was I scheduled a friend a day to come and talk, because although as a mouth cancer patient, you will have a speech therapist, you don't have that when you go home. And you can read and you can try and make the sounds from, you know, a printed piece of paper, but there's nothing that works better than spontaneous speech. And there's a couple of people in the Heads Together group that found as soon as they went back to work and they was talking to a lot of people, their speech became so much better.
Wow, isn't it amazing? Leaps and bounds. And actually your determination and focus sounds to have really sort of stood you in good stead, Janet. You do say in one of in your bio that you credit your extreme tenacity in being for your great recovery. You're very stubborn. This is an entirely positive trait. I see your friend Peter there laughing. You understand this, don't you, Peter? Yeah, nodding. Okay. We've got a couple of minutes and we've had one more question from Anthony. This is for you, Dan. Anthony asks, what or who encouraged you to approach Oracle Cancer Trust for funding?
Thanks, Anthony. Now that's really jogging my memory now. But I do remember the exact moment when I first heard about Oracle Cancer Trust, and that was 5 years ago when I was a senior house officer, and I had just entered into ear, nose, and throat training, and I attended the ENT UK National Conference. And at that conference, Mr. Peter Rees-Evans, prominent head and neck surgeon, stood up and said, we have the Oracle Cancer Trust and we're funding projects to get them off the ground. If anyone has a good idea or wants to put forward their research idea for head and neck cancer, we'd be happy to look into it. And so that was really, that stuck in my mind. And at that point, it was still early days for me in terms of research. But then when I got towards really looking for PhD funding and a substantial amount of money to fund my project, which was required for the research, I was very, very, very generous and very generous of Oracle Cancer Trust and to be able to fund my project. I'm very, very thankful for that.
Oh, well, we're delighted to, Dan. We very much, our strategy is very much about sort of finding early research and great ideas that have potential. And for those of you who maybe aren't so familiar with medical research, the early work that is done at university level is actually where you've got shots in the dark. It's like long shots, but it could be inspired. And if it's the work that has got more evidence behind it that gets closer to the drug company's interests of de-risking it. And so Oracle is very keen to make sure we've got this pipeline of brilliant ideas that are being tested out and can actually make it along that journey, so that drug companies or the health system kind of picks them up and sort of test them further. So we recognise that there's a real need for that kind of thing. We've got one more question from Gary. Hi Gary, you've joined us for a couple of our webinars. Thanks very much for coming along tonight. Would you like to ask your question yourself, or would you like me to read it out? You're very welcome to unmute if you would like to. I'm going to ask it for you. So Gary asked, he said, my primary cancer's never been found. Would the biomarker help find it? Really interesting question. And one of great interest to a lot of people, I'm sure, actually. What do you think, Dan?
So I think that's the £1,000,000 question. In terms of exploring IDO in head and neck cancer, we're certainly setting the groundwork, and a lot of the samples that we're testing the IDO on are taken from patients who were just diagnosed with head and neck cancer. And so there is the potential for that to be explored in the future. At the moment, our study is set up to draw conclusions from our observations with regards to IDO and how it may vary in different head and neck cancers and with treatment. But certainly we have the biobank, and we have those samples banked, and with the potential to explore that question in the future. So I think that's the question every cancer researcher wants to answer, and by all means that's something that we would like to answer as well with IDO. But at this point, I would say we're still in early days, so I don't want to say just yet for sure. But watch the space, and we'll put out our results when we have them.
Brilliant. Thank you, Dan.
I've got a quick question for Dan.
Oh, go on, Janet.
In my case, Daniel, where they obviously took the lymph glands out and found that there was no cancer in the lymph nodes, would the IDO have been useful in deciding as to whether I had a neck dissection or not?
Yeah, so Janet, that's a very interesting question, and interesting situation to think about. You know, how can we potentially apply IDO? If you think about the patients that we're recruiting and the samples that we're recruiting in particular, some of those tissue samples are coming from when patients first had their diagnostic biopsy. So that's even before the actual surgery to remove the tumor and or the lymph nodes. And that comes to the question of, can we answer whether IDO activity has any relationship with spread to regional lymph nodes? As I mentioned earlier in my presentation, how our regional draining lymph nodes can be important in this whole picture. If our IDO levels can tell us more about that, there is a potential that it can guide treatments as to whether or not patients would require further surgery or further radiotherapy. So I think to answer your question, yes, we can envision that potential. But it's about gathering, at this point, it's about gathering the evidence and the data to support being able to make that a viable pathway. Look into the biomarker, look into the biology of the tumor as soon as we've diagnosed it, and help us inform personalized treatments.
Thank you.
Great, Daniel, thank you. I mean, personalized treatments are really the end game for this, isn't it? It's the goal to be able to treat people for their particular cancer and how it's behaving in their bodies, and understand what their diagnosis means for them. So we're really excited about the potential of biomarkers. IDO is one, there may be others, and I know that Oracle will continue to invest in this kind of work. I want to say thank you very much to you all for bearing with us and staying for this evening. It's been a great session. Thank you very much, Janet. Thank you for sharing your story. for anybody who's watching is interested, we'll send a note out after this webinar with links to Janet's YouTube channel, so you can see for yourself the lovely backdrop of the south of France, where she's been recording lots of these. But that's, you know, that's not all. They're very practical and useful for people who are recovering. I also want to thank Daniel as well for, you know, what a great session, talking us through what is actually really complicated science. And I think I understood what you were saying. So I think you've done an excellent job. If I can understand it, I hope that you've all been able to sort of follow it, because this is like cutting edge stuff, really, people. So really, thank you very much for that, Dan. Really appreciate it. And thank you all for coming along. I know that you've all got, you know, different interests in head and neck cancer. One of the things I want to share with you is that the work that we do isn't funded by the government, it isn't funded by anybody else. It's the head and neck cancer community who makes all of this possible. So you're part of that. I want to say thank you for your part in this. It's the end of October, as you can imagine. We're gearing up for Christmas. So if you are minded to help us carry on with our work, it has been an incredibly difficult year for Oracle Cancer Trust, like many cancer research charities. So I'll be sharing information about what we're doing over the next couple of months, and maybe you'll find a way to support us as we build up to Christmas season. So thank you very much for joining us. Thank you, everybody. And yeah, have a great evening. We'll send a note when this has all been edited, so you can watch it again at your leisure and take more detailed notes from Dan's excellent presentation. So have a great evening and take care. Good night.
Thanks, Teresa.
Thank you.
Good night.